if I enumerate, is a makrocystic teratoma. These are common benign ovarian tumors, accounts for 10 to 20% of all the ovarian neoplasm. These are the sac-like structure that may contain hair, teeth, bone, cartilage, fatty fluid, and some of the oily, waxy substances and the thyroid tissue. They may range from half an inch to even 45 centimeters in diameter. These cysts, they grow slowly and do not cause any symptom until they rupture or get twisted or complicated in any way. So these ovarian dermoid cysts are the most common type of benign ovarian germ cells. About 1/3 of all the benign tumors, they are diagnosed during the pregnancy. They are ovarian dermoid cysts. They appear in both the ovaries, even in 10 to 15% of all the cases. So, from where do these originate? They are originating from the germ cell. These are the pluripotent cells which are capable of developing different tissues. They are characterized by the presence of various types of tissues, including hair, including skin, including teeth. These cysts are typically present at birth but may not be detected until later in life. There may be some genetic predisposition in first degree relative. So this is an ovarian dermoid story. Ovarian dermoid says that I developed from pluripotent cell. I may be diagnosed during a routine imaging procedure. If large, I may present as abdominal lump or the lower back pain. If large, I may complicate the torsion rupture or the malignant transformation. Oh, I got removed by the laparoscopy. That is the story of the dermoid cyst. What are the symptoms? Unless they are especially large or complicated, they do not cause any symptom. They may also present with the lower back pain during sexual intercourse, nausea with or without vomiting. Even when they are large, they may present as a urinary problem, abnormal vaginal bleeding, and abdominal distension and bloating even in few cases. The few symptoms may also be of nausea, vomiting, constipation, change in appetite. So there are few complications. These are ovarian torsion and the rupture. The large dermoid cyst can cause the ovary to twist on its supporting ligament and cutting its blood supply. This is a medical emergency requiring immediate surgery to untwist the ovary and potentially remove the cyst. So, in these cases, the symptom may be sudden severe pelvic pain, nausea, and vomiting. Other complication is the rupture. Here, the dermoid cyst can rupture, spilling their content into the abdominal cavity. This can lead to severe abdominal pain, and these cysts can burst, leaking their content into the abdominal cavity. Many times, this content is being absorbed. In 2% of the cases, less than 2% of the cases, there may be cancerous changes. There is great risk of the tumor becoming cancer if the age is over 45. Tumor is growing rapidly. The tumor has a diameter that is greater than 10 centimeters. So how do we diagnose these ovarian dermoid? We can diagnose by imaging. Many times they are being diagnosed by an accidental abdominal or transvaginal ultrasound. An MRI offers additional insight into the makeup of a cyst if an ultrasound doesn't provide enough information. DD, we have to differentiate it from the endometriotic cyst, from the cyst adenoma, from the tubo-ovarian mass. While differentiating from the endometriotic cyst typically present with a low-level echoic or ground glass appearance because of the blood inside. May have a thick wall or the internal echoes, while the dermoid cyst with the variable amount of the solid material inside have a characteristic tip of the iceberg sign on ultrasound. So, how do you manage the dermoid cyst? Some type of the ovarian cyst eventually disappear on their own, but dermoid cyst doesn't disappear. We have to remove these cysts. So treating ovarian dermoid cyst require removing the cyst, and rare cases the affected ovary even. It depends on the patient's plan of the fertility. Minimally invasive techniques like laparoscopy are often preferred for the ovarian dermoid, while the larger cyst with the complication may require even laparotomy. This is a case presentation. A 28-year-old female presented with a case of PCOS. Her last period was when she presented to me was 20th July 2020. She had a pain in right abdomen for 15 days, and on ultrasound we noticed an echogenic mass in the right ovary, 5.2 centimeter. It came to be dermoid cyst, and the diagnosis was even proved on MRI. We ruled out it's to be endometriotic cyst, and then the patient ovarian cystectomy was done laparoscopically, and removed tissue was biopsied and came to be dermoid cyst, and she has been kept for IVF treatment. The other patient of the giant ovarian dermoid cyst is an adolescent, a case report. In this, the patient was presented to us. This is a rare and challenging event present as a giant masses in adolescent. Importance of the fertility reservation is there in this very row. The patient was 15 years old. Her chief complaint was a progressive abdominal distension and the lower abdominal pain for last 6 months, and no other important history. On abdominal examination, there was a abdominal palpable mass reaching up to the umbilicus and was firm and non-tender. On imaging, we found on ultrasound there was a large cystic mass with echogenic areas, hyperechoic line showing here and the calcification. MRI was also in same favor, and we found it to be a suggestive of mature cystic teratoma. So we planned laparoscopic surgery and did the laparoscopic cystectomy. So careful cystectomy done with the preservation of the ovary, and there was no spillage of the content. These are the intraoperative picture. This is the picture of the surgery. In this, we use the endo bag just to avoid the spillage. We cut and just see the endo bag has been used in this surgery, and we have carefully put this cyst into the endo bag. This is the endo bag, so that to avoid the spillage. This is surgery which we are doing. So after the surgery, the gross anatomy that shows cheesy sebaceous material, hair, tough tooth-like structure, and we diagnosed it as a mature cystic teratoma. The post-operative care course was uneventful recovery, discharge on day 2, follow-up 1 month and a 3-month normal ultrasound. So counseling done for recurrence, this and the fertility monitoring. So early diagnosis help in fertility sparing management in these very cases. So in conclusion, I can say that giant dermoid cysts in adolescent are rare but manageable. Other case is a torsion of the ovarian dermoid cyst with a preserved ovary. Ovarian torsion is a gynecological emergency, common in reproductive age women with underlying ovarian pathology. Here also early diagnosis and conservative management can preserve the ovarian function. This is a patient of 22 years old, acute onset lower abdominal pain and nausea. There was no history of fever or any other bowel complaint. Her vitals mild tachycardia. She was afebrile, abdomen guarding was there. On pelvic examination, tenderness in adnexa and provisional diagnosis was of the ovarian torsion. On imaging, ultrasound with Doppler enlarged ovary with a 7 cm complex mass was there, and there was absence of the reduced blood flow suggesting of the torsion. MRI also confirmed the diagnosis in this very case. So there was a DD between the functional cyst, hemorrhagic cyst and appendicitis which was ruled out. Ultimately the surgery was planned, emergency laparoscopic, and finding was the right ovary torsion with the two twist. Dermoid cyst 7 cm, detorsion was done and ovary reperfused. Cystectomy with the ovarian preservation was done in this very cases. These are the intraoperative picture. You can see histopathology showed mature cystic teratoma which was confirmed and contained for the hair sedation material, and there were no signs of the malignancy. So we discharged the patient on the day 2 with everything normal ovarian vascularity, and counseling on recurrence and fertility was done. So ovarian torsion requires a prompt diagnosis, and conservative surgery can preserve the ovarian function. Laparoscopy is preferred here. The third case is bilateral ovarian dermoid cyst with a different content. This is my team. Because of short of time, I am not going in detail. Some challenges in management of the dermoid cyst are malignant transformation in a dermoid cyst rupture with a chemical peritonitis, ovarian dermoid cyst coexisting with endometritis, laparoscopic management of the large dermoid cyst in the first trimester of pregnancy is also a challenge. Recurrent dermoid cyst after the cystectomy, ovarian dermoid cyst mimicking other pathology like appendicitis, tubercular abdomen, unusual content in a dermoid cyst. So special considerations are the management in a specific population. These are the pediatric, adolescent and the postmenopausal group. Fertility preservation and impact of surgery on the future fertility is important. Psychological aspect of diagnosis and treatment is very important. Multidisciplinary approach involving gynecologists, surgeons and the other specialty. So prognosis is good for the benign cyst treated with the appropriate surgery. Importance of early diagnosis and treatment to prevent the complication, and long-term follow-up to monitor for the recurrence or the complication. The future direction are advances in the surgical techniques and imaging modality, research into the pathogenesis and prevention of dermoid cyst, and improving the patient outcome and the quality of life. So that is